morning, everyone. Welcome to the fourth session of our Opioid Prescribing and Overdose Prevention Learning Collaborative. I'm Christine Lamb, a QIA or Quality Improvement Advisor for Superior Health Quality Alliance, or Superior Health. Superior Health provides support for healthcare organizations in Minnesota, Wisconsin, and Michigan under a federal grant from the Centers for Medicare and Medicaid Services. Today's session will focus on recommendations 6 and 7 from the CDC's updated 2022 Clinical Practice Guideline for Prescribing Opioids for Pain, which address deciding prescription duration and providing follow-up care. After today, there are 2 more 30-minute sessions where we will discuss CDC's recommended prescribing practices 8 through 12. Superior Health developed an opioid prescribing and overdose prevention toolkit to complement these sessions, and we will be putting the link in chat a little bit later. John Glover, who is also a Quality Improvement Advisor at Superior Health, introduced us to that toolkit in session 1. And John will be helping us with questions or comments in our chat today, as well as providing links to various materials throughout the session. Before we get started, if you could please add your name, organization, and role in the chat, as well as any others you may have with you today. That way we'll have an idea of who our audience is here. A few housekeeping items. We will have 1 polling question at the beginning of today's session and 1 at the end of today's session. We will also be putting a link to a brief survey for this session in the chat toward the end. And we will try to give you a few minutes to fill that out. If you have a question that you would like to ask verbally instead of in the chat, raise your hand and we'll be happy to take you off mute. Dr. Dibble is our speaker today. Dr. Dibble, take it away.
Thank you so much and welcome. Good morning, everyone, and thank you for attending. This talk is session 4 of our learning collaborative of opioid prescribing and deciding prescription duration and providing follow-up care. In your reminder emails for this session, there were links to sessions 1, 2, and 3 for review if you would like to view those. So this is a building collaborative. Next slide, please. So objectives today. So our hope is that our participants today will be able to determine the duration of initial opioid prescription and conducting follow-ups. Participants will be able to assess risks of opioid therapy during treatment phase, and participants will be able to evaluate risks for opioid harm, related harms, and incorporate into management plan strategies. Next slide, please. So to get a sense of where our audience is today, here is a polling question. And within this talk, we'll review and ask the same polling question. So which presenting in the ED could be prescribed opioids? A patient with a fractured toe, a patient who had a hip replacement one day ago, I'll say, a patient who has a migraine headache for the last hour, or none of the above. And if you all would just select a choice. Okay, I have the results. I'm not going to give the answer yet. So initiating opioid therapy, the CDC recommends addressing the 4 following areas. So what happened was the CDC basically had an aim or a goal to address, as we know, the massive epidemic that's going on with opioids. So in that, they had 4 buckets that they were going to create 12 guidelines from. And so that's what the overarching theme of these recommendations come from these 4 areas. One of which is determine whether to initiate opioids for pain or not, selecting opioids and determining the dosages, and deciding the duration of initial prescription and conduct patient follow-up, and assess risks and potential harms of opioid use. So that was their goal with these recommendations. Next slide, please. So recommendation 6, and this is taken from the CDC, exactly. So when opioids are needed for acute pain, clinicians should prescribe no greater quantity than needed for the expected duration of pain severe enough to require opioid therapy. I'm going to go through the implementation, then I'll expound on the recommendation, but that is what it is as written. Next slide, please. So recommendation number 6, the implementation considerations. So when we look at non-traumatic or non-surgical acute pain, this can often be managed without opioids. I know, and I can give you an example of myself. When someone says, oh, okay, take some alternate Tylenol, ibuprofen, I typically roll my eyes because I'm like, I just have for example, I fractured my tibia and I was in horrific pain. And the physician said, we're going to alternate between Tylenol and ibuprofen. And I was like, wait a minute, I have fractured my leg. Like I couldn't walk. So he wouldn't prescribe even tramadol or anything. So I did what he said. And lo and behold, I had no pain. So that is something to really look at. These non-opioid therapies, they do work. And sometimes we don't give them the chance to work. So avoid prescribing additional opioids to patients in case pain continues longer than expected. That really is related to if you're looking at pain that is happening longer than expected, there's usually an underlying problem. So that's something to really look at deeper than the pain, if you will. Post-operative pain related to major surgery, procedure-specific opioid prescribing recommendations are also available with ranges for amounts of opioids needed. So this is very important here insofar as these days it's not prescribing for 30 days. It's 14 days, 7 days, 5 days, 3 days, and with a very close measurement of not over-prescribing. To minimize unintended effects of patients, clinicians, practices, and health systems, so they should have policies and mechanisms in place for any patients who do experience severe acute pain that continues longer than expected. Again, then we have to dig down of why. Why is that happening? Maybe there's a different etiology. Patients should be evaluated every 2 weeks if they continue to receive opioids for acute pain. I'm going to read that one more time. Patients should be evaluated at least every 2 weeks if they continue to receive opioids for acute pain. This is so important because you could potentially harm a patient or they could be addicted when they didn't need the medication in the first place because we didn't assess. So the assessment and the plan with the patient for recommendation 6 is really the underlying foundation. So then we get into if opioids are continued for more than a month, then we're looking at chronic pain. So that shifts our whole thought process from acute pain to chronic pain. We need to really start looking at naloxone really on prescription, but really if they're going to be on it continually. And what we don't want to do is have someone on long-term opioids when they don't have to be. And by default, they were on long-term because we didn't manage them well on the front end. So if a taper is needed, taper durations might be adjusted depending on the duration of the initial opioid prescription. So when you have hit your goal where the pain has gone down to say, 3 or 4, then we need to start looking at tapering. And this again goes with your patient-focused assessments and you on board with the patient. So when you prescribe an opioid to a patient, as a prescriber, I look at it as I'm prescribing myself an opioid, and that is a huge responsibility. And I have to keep my arms around that patient until they have discontinued that opioid, or we have a plan for continuing. So those guidelines are super helpful when you think about who is on opioids and how to prescribe them. Okay, next slide, please. Recommendation 7. So clinicians should evaluate benefits and risk with patients within 1 to 4 weeks of starting opioid therapy for subacute or chronic pain or a dosage escalation. You may need to go up. So that's, again, your assessments are super important here. Clinicians should regularly reevaluate benefits and risks of continued opioid therapy with patients. So that's as it's written. And then next slide, please, and we'll go into the implementation. So considerations with recommendation number 7. So when you evaluate your patients to assess the benefits and risks within 1 to 4 weeks of starting long-term opioid therapy, a dosage escalation, they may be having breakthrough pain, for example, which means you have prescribed enough to cover their pain, but for some reason at 3 in the morning, they have pain. So that is an adjustment of schedule. Again, throwing in potentially some ibuprofen, Tylenol, be very careful with that. Kidney function, 2,500 milligrams of Tylenol max. And so hydrocodone has 325 in it as well. So we have to really study that and look at that, make sure we keep the patient safe. Then interval follow-ups within the lower end of this range for extended release or long actings, and are started or increased because of the increased risks of overdose within the first 2 weeks of treatment. And this is honestly when it happens, or when the total opioid dosage is greater than 50 MMEs, and that's morphine milliequivalents. The max dose, just so you know, is 90. So when you start getting to 90, you need to really look at if you're making traction with pain. And if you need to titrate up, titrate down, discontinue. Consider shorter evals. If you just can't get your arms around why is this person continually having pain. An initial follow-up interval closer to 4 weeks can be considered when you start immediate release. So when you start going from short-acting immediate to long-acting, you need to really start evaluating your patients more frequently to ensure that the treatment is appropriate with the plan and that it's patient-focused. So when obviously seeing your new patients, maybe they're already on opioids. So establishing a treatment plan with goals, including functional goals. I'll stop there for a second. And when you think about function in opioids, in geriatrics in particular, that's something that should be of top of mind because fall risk is of paramount importance. The cascade of fall risk, the cause could be an opioid, but maybe they're on anticoags, antiplatelets, hit their head, that causes another problem, breaks a hip. So we start this cascade of negative outcomes if we're not really on top of managing and monitoring our patients. Geriatrics also metabolize opioids differently. It's something to be very, very mindful of. So the other point that is very important that I think gets glossed over sometimes is to ensure that the treatment for depression, anxiety, and other psych comorbidities are optimized. So years ago, pain, they figured out it's not just physical pain, it's emotional pain. And I would say in practice, when I can't get someone tapered down and their pain is minimal, I start opening up a psychosocial or psych conversation about depression. Are you feeling hopeless? Or like, what's going on? And sometimes we are masking emotional pain that can morph into physical pain. But particularly in geriatrics with social isolation, COVID really took them down. That's something to really, really look at because pain meds make all of that go away, but maybe they just simply need an SSRI. So really look at the head to toe angle of prescribing, duration, how to taper, increase of opioids. And lastly, your plan with your patient. It is the utmost important that they are part of the plan. What's working, what's not. Are you constipated all the time? I've had plans not work because of that. And then when I treat the constipation, there's diarrhea all the time. So these sorts of things are very helpful in making this treatment plan. And obviously you figure this out with your assessment and your follow-up. Next slide, please. So here's a case study, and I will read it. And then if you all could just throw in the chat some thoughts and ideas. I'd like to make this interactive if we could. So Mary, who is a 65-year-old female, presents with right strained ankle pain from a fall 3 weeks ago. After the fall, she went to the ED assessment. Patient was given 325 milligrams of hydrocodone prescribed for 14 days every 6 hours for pain. So after the 14 days, Mary is still complaining of pain. And so upon physical exam, she can flex, point, rotate her ankle. She says she has a pain of 3 out of 10. She states that she's sleeping and the pain's not waking her up at night, and she can perform her activities of daily living. She can also ambulate with her boot on, and she can bear weight without pain when the boot is removed. The x-ray reveals there are no fractures or breaks, but Mary is requesting a refill of her hydrocodone. So throw in the chat some thoughts. What would you do? What would you ask? What are your initial thoughts about this case? Ooh, okay. Jan, I like it. Any other? Kelly, Angela, anyone? I taper her. Ooh, Candy, smart girl. Okay. Okay. So this was a case I had, and the reason, it seems like an elementary case, but this, I would say, would be 50% of the things I would see in the ED, maybe 60. And when I think about these very simple cases, and I think about the epidemic, and I think about harms to patients, and I think about outcomes, this case study is what we see all day long. So breaking this down, Mary had a sprained ankle. She fell, okay? Obviously, first thing to do would be look at her med rec. I think looking at meds are super important when prescribing pain medication. And for some reason, she was just given hydrocodone initially. So what do you think we maybe should have done? PT, OT, massage, great. No refill, yeah. But what should have happened initially? Does anyone have any thoughts? Maybe some Tylenol, ibuprofen alternating. Was she assessed? She was prescribed for 14 days. Did she ever go back to her doctor who prescribed it? I don't know. But what happened was that I looked in the PMMD, and she was from Kentucky. Icing elevation. There you go, Jan. Thank you. There we do. We can do the rice, right? Rest, all the things that we need to do. So when I looked in to check for her narcotics that have been prescribed, I found out that she, in fact, had been prescribed hydrocodone in Kentucky the month before. So meanwhile, she has 2 prescriptions of like 14 days. So she has 28 days. And if I were to do the math, that's 4 tabs a day. So 28 times 4. So that's a lot of medicine for a strained ankle. That right there is how the epidemic continues. So this is where providers, people who aren't prescribers or providers, or that prescribe to provide rather, you're the eyes and ears. You're the one that says, hey, Mrs. Smith or Mary's been on 14 days of opioids for a strained ankle. What's this? I don't understand this. Asking the questions, because these things are missed. And then we continue this epidemic and we harm the patient. So what happened here, what I did with her was I explained to her the risk and benefit of opioids. I asked her if the benefit versus risk, if there was more benefit. When she thought about it with constipation, falls, the whole thing, all of it, she was like, well, not not really. I said, okay, let's try some ibuprofen, alternated, ice, elevate. Let's do all the things we do for a strained ankle. If it doesn't improve, and I think I said 48 hours, then what we do is we do an MRA. Maybe she has ligament issues. Maybe there's some other things going on, but we don't go straight to the opioids. And I would see it all the time when people would come in. So that is something to be very mindful. That is the acute, non-surgical, probably doesn't need an opioid. And if she does, there's something else going on. So that's really kind of the thinking, the stepwise approach of thinking, really critically thinking, and understanding how important it is when you prescribe this, because you could be potentially adding to the epidemic without the critical thinking piece. Pain medicine is wonderful when prescribed and used correctly. It does improve quality of life, and it does help situational pain. So next slide, please. Okay, so summary and takeaways of recommendations 6 and 7, and I do urge you to go back and look at the other recommendations. It's a nice reminder. Some have changed, and CDC, Medicare, they're doing everything they can to mitigate this explosion of opioid crisis. So ensure opioid therapy is necessary versus non. Prescribe the appropriate duration of opioid therapy. Low, slow. That is the point there, low and slow. Reevaluate opioid therapy with the patient, patient-centered care with the patient, plans with the patient. Weigh the risks and benefits of continued opioid therapy. That's constipation, that's fall risk, that's anything that happens negatively to the patient. It may or may not. It may be a benefit versus a risk, or it may be a risk, but the benefit outweighs it. So these are all of the things you get from your patient. These are all the things that you get in creating a plan with your patient. Next slide, please. So does anyone have any questions or stories or anecdotes or just some feedback that you'd like to share with the team?
While we're waiting, John, if you wouldn't mind putting that little survey, post-session survey in the chat. We'd love to hear everybody's feedback. And if they could take a moment while that link is there, that would be really great. We can also put the toolkit in the chat for reminder where that's located.
Thank you. All right, Christine, I'm sorry to interrupt, but we do have the polling question up now. So the answer is none of the above, and we improved by 10%, which is great. And the reason it's none of the above, I picked hip replacement 1 day ago. I'm sorry, that was a dangler, that was a teaser. That patient is probably still in the hospital. And then obviously the migraine, probably more going on with that, but we don't go straight to opioids. So it's none of the above. Very good, thank you.
So Rachel, can I ask a question?
Please.
So, but if the patient is post-hip 1 day, she's likely, even if she's in the hospital, there is a likelihood that she might be offered opioids for pain control.
No, 100%. This was just the patient going into the ED.
Oh, okay. Well, you can up the answers by 1 then. I didn't catch that part.
No worries. I was trying to give a gimme there on B. Okay, next slide, please.
Cindy said same thing for her. So, or Jan said same thing for her. So you can re-ask the question then and we'll get it this time.
And we also have Angela put in the supplemental materials would be helpful for partnering professionals, example nurses, social workers. Okay, well, I think that John did put the link to our toolkit in the chat.
So Angela, these materials are wonderful, the toolkit. And then you'll have access, of course, to the recordings as well.
And here are the dates for our upcoming sessions on the CDC's recommended prescribing practices that Dr. Dibble will be walking us through. If you haven't already, please register for the sessions by clicking on the link. I think John's going to drop that in chat for us. And keep in mind that you will still need to click on 2 registration links once you get to that page to ensure you're registered for all sessions. Thank you for a great presentation, Dr. Dibble, and the great comments in chat and a couple of questions that we had. On this slide, you'll see Superior Health's Connect link. If you haven't joined already, please do. Connect is used as a platform to share information and continue conversations on a variety of health topics. And this does conclude our presentation.
And Christine, I put the link to this. I put the link to the survey in the chat as well.
Great. Okay, so the survey for our presentation today, awesome. And then we'll also open it up. If there are any other final questions before we sign off.
Actually, I have a question. Sorry.
Yeah.
I saw a comment in the chat, Jan, and I know we're right at time here. So you said would the patient in that case need to be tapered, considering she only had it for 14 days? Were you talking about the case study or? Okay. So in the case study, the patient that was prescribed it to begin with should not have been prescribed it. But hypothetically, if she did not go back to the ED and she went to the person who prescribed it, maybe the orthopedist, he should definitely be tapering her 100%. Or looking maybe for infection, osteomyelitis, maybe tendons, ligament, all sorts of other things, because for a sprain, you should not be having that kind of pain for that long. With the hydrocodone did not particularly help her, as she stated.
All right, great points. Thank you, Rachel, for adding that in. Hearing no other questions, and we are at time, we want to wish you all a good day and thank you for joining us. We will see you next time.
Thank you so much.